Hey everyone, this is the Nips and Sips podcast show featuring me. I'm Dr. Jeremy Boyd and my usual partner in crime over there, Dr. Brandon Cruz. Today we're going to be talking of a little bit different, kind of almost like a case study, but kind of taking it a little bit further of actually saying no to your patient. So Brandon had a patient that I saw while I was in my fellowship mentorship with him. And it kind of carried over into a lot of aspects of, I believe, physical therapy and how we treat patients. But before I get going, Brandon, how's it going?
Going well, man. Decided to talk about our fusion topic today. Definitely. Couple big announcements and shout outs I want to make. But as usual, let's start with the drinks. And let's start with you because you always lead the way.
All right. And for all the viewers at home, if we got any, I am wearing shades for a particular reason, not just to be trying to get myself more cool because my cool points are down. I had LASIK a week ago, and a little bit of a miscommunication of the post-op outcomes for a little bit, which is always good to talk about for our own patients. But yeah, I'll be rocking shades today. Hopefully that helps boost our viewers and listeners. Maybe not the listeners so much, but I'm drinking Nightcap. Actually, this is pretty early, or this is more of our earlier session for us. We're doing this at 8 o'clock in the morning. So this is kind of a little bit false advertising here, but it is a stout. I feel like if you're going to have a breakfast beer, it should be a stout. So it's a 9%er. I've had this for a little bit, just sitting in my fridge for a good moment. So we'll see if I get through this puppy. It's called Nightcap Imperial Stout. Brew with candy cat mushrooms. That might be aggressive in the morning, but
this sounds delicious. You have any more of those? I might have to have one of these.
Candy cat with candy, like a candy mushroom, not like real mushrooms, right? Or is that?
I don't know. Isn't candy mushrooms what they put on top of the potatoes for like Thanksgiving?
I have no idea. I'm going to look this up. Can buy. Oh, this is an interesting name. 54 degree. It's like longitude latitude 54 by 40 beer brewing company in Washougal, Washington. I don't know how the heck I got this beer. It was just sitting in my beer fridge. So definitely an interesting one. But drinking out of my mainstay glass from in Philadelphia. So this is probably the only one big enough to fit all this beer. But Brandon, what about you while I pour this?
Yeah. So I've had this before on the show. It's the Bacardi Anejo that was gifted by our amazing, awesome patient Manny. He's a patient of ours who had a stroke. We don't normally see it, but he was referred to us by a friend of mine who closed down his practice. And he came to us, but the guy's awesome, genuine as hell, funny as hell. I can only imagine what he was like prior to his stroke because, you know, he is obviously battling some of the mental aspects of it as well, depression and things like that. But he had gifted this to me. Awesome. We've had it before. It's kind of has a vanilla hint to it. Since it is early in the morning, I'm probably not going to pour too much here, just because we've got a full day ahead of us. You're brave with the 9%er. The reason why I picked that looks thick, bro.
Yeah.
The reason why I picked this is because one of my former interns, Emmett, graduated in May, passed his boards last month, just got his license the other day. So big shout out and congrats to Emmett Rojo. You guys, if you guys are regular listeners, I've talked about him. We've talked about him before. We've hazed him a lot. Like to joke around and embarrass him a little bit, but he's a good sport about it. So we hired him because he's a work hard, play hard guy.
He is.
And we love that. So big shout out to Emmett. Congratulations, bud. Proud of you. Him and Manny had an awesome connection. Emmett really took care of him, actually hit some big milestones treatment wise, did some like outside the box treatment, some neurodynamics, some cervical mobilizations with neurodynamics, got him out of his flexion contracture for the most part. He still has it, but I mean, he came in like this and now he can move and grip things better. He was able to tie his shoes. He's walking without a cane now, like some pretty big stuff. and he hadn't made those milestones in 3 years, and then within 4 months of being with us, he did that. So
Awesome.
those two are linked. Manny loves Emmett. They joke around and haze each other. Emmett took $5 from him in a bet and actually made the guy pay up. So that was pretty ballsy of him, pretty funny. And then last thing, Emmett was awesome enough. He's quite the craftsman. Made me this. Knowing Charles Barkley is one of my favorite, if not my favorite player ever. Overheard me talking about it, remembered it, and made me this gift. A poster. So I have to actually hang it up, but I've been waiting to do it on the show before I hung it up. So Emmett, here's your shout out, brother. I know you I didn't want you to feel left out, man. Congrats.
Cheers to Emmett. Congrats on joining Pursue.
Yeah, so Emmett's helping lead the charge over in our new office in Hoboken. We just opened that this week. This week is, I know this showing is going to go out probably in a couple weeks after. Today's the 16th of September, so we opened on Monday. So Emmett's helping lead the charge there. So awesome. Anyone who has any friends or family in the Hoboken area needs some PT, we're there now in downtown over on 80 River Street. So come on down.
That includes Hoboken, Jersey City, New York. You got fly in from Massachusetts to come see these guys do it. Whatever it takes, the kings of the north. But congratulations on the second office. It's awesome stuff.
Thanks, man. Appreciate it.
Cheers.
All right. So how's your drink? What rating are you giving it?
It's solid for 9%. I thought it was gonna, kind of put me on my ass. It's extraordinarily smooth, which is sometimes the higher you get, but usually it's at 10% threshold. That's when it's just like it goes from like you can feel the strength to like wow, it gets like buttery smooth. So really smooth. Standard, what you think of an imperial stout, nothing like too jumping at me. I don't know if I just don't know what candy cap mushrooms are. I can't really taste that on my palate. Maybe it's not versatile enough for my palate there, but I'll give it a solid 8. Solid. I like this. I said I wasn't going to drink it all the way through. Who knows? This is going down a little bit easier than I thought. So I'm going to give it a flat 8. It's good. I'm happy with my choice today. Not so much with my coffee though. I don't know about your experience there, Brandon, but I don't like girls, not to talk too much smack on my wife, can never settle on a creamer of any sorts. It's always, I know I usually go in black, but I was just like, I saw a creamer, and every time I open up the fridge, it's a different creamer. And this one, I just put a splash, just a little bit, just to like test it out, and it instantly made the whole coffee go like borderline looking like milk.
A little too much, yeah. Well, so what flavor is it? Are we talking flavored creamers here?
It's like a flavored creamer. I think it's hazelnut E.
All right. Yeah, I usually buy the regular creamer. I like just a little bit. Today, actually, I'm drinking my coffee black, oddly enough.
Wow. Switched.
But I was just out of milk and cream, so whatever. I need to go shopping. There's a good creamer for a while I was hooked on. It was like the Cinnabon creamer. It's fucking crack, dude. It's awesome. I wasn't big into creamers, and then like I had it, I was like, this is delicious. And then after a while of having it, it started to mess with my stomach. So I think I was just having and I was also having like cups of coffee that's like this big in a probably 25-ounce container. Yeah. So I think it was more the coffee than the creamer. But anyway, I've cut back a lot on the coffee. I try and have like 2 cups max, like on the when you pour it up, and that's it. So I've been cutting back on that. I cut back on the flavored creamers. Trying to drink more water and things like that, but yeah. All right, so we might have to change our episode to coffee talk and creamer talk. The way we're going. All right,
let's talk about this patient. Let's talk about
fusions. I guess Jay, what I know you. So everybody in the audience, Jeremy kind of makes a list on a docket that we share, and we just go over topics that we discussed about and ran, different points in time. And then, we go through it, and it's like, all right, what do we want this episode to be? So, we're like, you want to do it on Fusion? And he's like, yeah. your story, resonated with me and popped out. So I was like, what story? But I just talk too much. So Jay, what about that story, I guess, as an intro to this topic of fusions and educating our patients on why, or hopefully why not to get fusions.
Mhm.
And then we'll go from there. But yeah, what was kind of what stood out to you?
Yeah, so I believe his name, oh, I guess we'll just say patient,
Yeah.
K, pick a random letter there. Um, when I was up there for fellowship, mentoring and that sort of stuff, just seeing him around, I think you said he was an interesting case, or maybe even Emmett or somebody was talking about him a little bit. And I believe at that time he had, correct me if I'm wrong, it was like 6 fusions or 6 major back surgeries, or maybe even a little bit more.
Yeah,
Uh,
it was 5 or 6 surgeries in general. I think the first surgery was a microdiscectomy, and then he
yeah,
had about 4 or 5 fusions at single level and low back, and then that became 2, 3. It became multi-level multi levels for multiple fusions.
yeah. So one that was surprising, I never experienced anyone with multi fusions. I don't get too many fusions. Actually, I don't know if I had a fusion since maybe way post op. Just mentioning your past medical history, uh, sort of thing. But I don't get too many fusions since I started my practice. So that was one interesting. Just kind of see this trickle down effect in the negative way of getting kind of these fusion or surgery after surgery. But what really resonated with me, and just watch him in the clinic, he loved everyone. He was interactive with therapy. He was participant. He's an older gentleman. We're talking about a different generation here. We'll talk about that. A lot of them are unfortunately misguided. But at one point you said, well, I actually said, I will, like, correct me if I'm wrong there, Brandon. You said something along the lines of, I won't treat you if you go for another surgery. Almost kind of like putting your foot down, looking in the best interest of your patient. And and especially as a business owner, not alone as a PT, and we have this altruistic nature of trying to help everyone, no matter what they do, even if they're knuckleheads, but as a business owner and that sort of stuff. But to say that, at first I was like, whoa, but then to hear your rationale about it, and probably the impact that happened as a result of you doing that, I thought was amazing. So I'll leave that to you and kind of where that story picked up. I don't want to mess it up probably any more than I did.
Yeah, I mean, I should have probably looked up the email prior to this episode. I mean, this happened a few years back. I think right around the 2019-ish into early 2020, so now we're butting up against COVID as well. But I had first come to see him after he had 2 surgeries within, 2 fusions within months of each other. So then I got him and we were rehabbing. So this had to be spring, late winter, spring of 19, I believe. Came to me after his fusions. Okay, still having pain and ridiculous symptoms. I mean, very deconditioned. And this is a person who used to run marathons. He's a big runner, loves to hike, loves his family, loves his grandkids, likes to be able to play with them, and he just couldn't do anything. I'd probably say, rightfully so. His morale is, taking a hit. His ego's probably taking a hit a little bit. He's gone through a lot in the recent, months and even years, watching his function deteriorate. But we're rehabbing him, and he'd have his good days and bad days, which is normal. Normal after a surgery like that, normal after somebody of that age as well. And we got to the point where it was the summertime now, and he, wasn't happy with basically the pain. Not necessarily his function, but his pain. Like he was always stiff. He had some numbness tingling still. I think part of it was, like you said, expectations of what his outcomes were going to be. Partly believe some of his expectations were he's going to be able to go run again, run, marathons. And, he wasn't able to. So kind of, long story short, back and forth. I think he went away for the summer, down the shore with his family. And I get, some emails from him, and he's like, I'm thinking about going back and getting another surgery, yada, yada. And, this is after months of, education, examples, talking about the research and the evidence. And, we don't want to get surgery, or we don't want to get fusions just for pain alone. At this point, he's not having any, true neurological things. We're not having any, significant weakness, myotoma weakness, bladder and bowel dysfunction, anything like that. So at this point, if you're just getting surgery for pain, and a fusion is for pain, it's probably not the best thing. I think we can all agree that we need to begin to move away from that if we already haven't, and educate our patients about that. So long story short, I basically told him, I was like, listen, I understand if you want to do this. We all have our own process of dealing with things. But if, you decide to continue going down this road, I don't think I'm the provider for you. And, this was after, him always saying, I'm his provider, singing my praises, X, Y, and Z. He wants to get better. He wants to get better. And it's like, dude, you have to pick kind of one or the other at this point, not to try and be authoritarian. I can't even talk right now, but, not to be a dictator, but we wanted to, get him away from going back, to the well there of getting surgeries. So, he's like, no, I think you misunderstood. I think you misunderstood. I was like, Kevin, I totally get it. You're unsure. You understand where I'm at now. If you want me to set you up with a second or third opinion, that's great. But I think you have like some reflecting to do on what you really want and what your outcomes, what you want to be able to do. And I kind of left it at that. So he's just kind of like, okay. And then I didn't hear from him for a while. And then he, in that time, went and got his fusion. And this time he got everything fused from, T1 down. Called me again. He's like, hey, I went forward to surgery. I'd love for you to do my rehab again, X, Y, and Z. He's back now. I'm not going to turn him away, but it was hard to, he's a genuine guy. He's an awesome human being, but it was kind of painful to be like, you need to stop going down this route. Now we're in this, we're still kind of dealing with pain and stiffness and things. And, I think his surgeon was like, well, next is doing the cervical spine. I was like, no, like, when are we got to stop here, bud. So hopefully staying away from that. He's got some other stuff going on. We'll leave it alone at that. But yeah, there's, a lot of takeaways from that we can hopefully unravel and layer just some of the research, some of the some articles I have here from 2002 that was done in the New Yorker about perspectives of surgeons performing this stuff. I think Jeremy's more so alluding to just me having, I guess, the wherewithal to be like, hey, maybe I'm not your provider if you're going to keep going down this route.
Yeah, I thought that's just impressive. And then I think that in itself probably at least challenged him to rethink things. Like you just mentioned some things of like, oh, the surgeon doesn't seem to mind. Fuck it, we'll fuse everything. And I would think at least with what you did, at least he's, maybe like was considering, all right, maybe I need to stop here. Maybe I shouldn't go and fuse my cervical spine and that sort of stuff. So, we brought up on the show before is, we sometimes can't teach an old dog new tricks in a sense. And especially with our older generations, where that was the thing, the surgeons, the top of the food chain, they're the great white sharks of, healing per se. What they say goes. And, obviously that's what their bread and butter is, but some of their surgeries are ineffective. And especially with what Brandon's saying, he's trying to guide this patient, where, the fusion's not good for pain. When has any of the previous surgeries or fusions helped you with this pain? And, I thought, this patient was unique, but the more and more I listen, I haven't got to see her. I've been trying to see her as a girlfriend of a patient of mine right now, who's like low 20s or mid 20s, is already have a fusion. Um, is now in pain management doing like contrast therapy in her feet.
Mhm.
Um, so very interesting stuff. And they're already talking about another surgery and that sort of stuff. And you can already tell her she's got all these other, factors. And I only talked to her for like 20 minutes. Um, of all these other things. And I gave her some evidence, talked about some things, and hopefully with just that conversation or a little bit is like, all right, maybe we need to stop here. I think we beat up ourselves a lot for the patients that I guess go down and have multiple surgeries. I do like ACLs and such and so forth. And sometimes that's just their process. But if you can stop that line where, hey, this person, if it wasn't, for some good education, would have had, 10 surgeries. I've met people who've had where, in the teens and almost into the 20s of surgeries. And I beat myself up for individuals that get one. And I think it's good time education, and then doing something what Brandon did, where essentially put your foot down and said, for the better interest of the patient, of I don't think this is the best option for you. If you really want my services, you're gonna have to, I guess, meet me halfway. And that changed his hopefully his the rest of his life to at least some degree. I know you were talking about before that Kevin, oops, sorry, okay, it's only first name, is referred a ton of people to you and that sort of stuff, his kids and all that sort of stuff, other family members, friends, and that sort of stuff. And maybe they're not so far down that medicalization rabbit hole, and you can at least change their lifespan. He may be kind of prefixed on all that sort of stuff, but maybe the future generations are permanently changed because you're able to get in and kind of change his perspective a little bit.
Yeah, well, hope so. It is unfortunate because a lot of what he was going for, it was just pain. Unfortunately, yeah. Well, what number do you say enough is enough? That okay, you had one surgery, you had two, you had three, you had four. That maybe some other things are going on here. Plus, like you were talking about, where your 20-something-year-old patient, the psychosocial aspects that either underlie what's going on or are caused because of what's going on. I've had surgery. It's I had a labral surgery years ago, and it brings in doubts to is this going to be the same again? Is this going to tear again? Can I go back to doing what I did before? There's pain there. There's, if I don't stretch it out and mobilize it and keep it loose, it starts to bother my neck and things like that. Luckily I have the knowledge and education to work through it individually or seek help if I need it, but also understand like the outcomes and where to go and things like that. Not all your patients or most of your patients have that ability. And there's an article that was actually published, written in the New York Times in 2002. When we're talking specifically about fusions, it was written by Jerome Groupman. It's called "Is a Knife in the Back? Is Surgery the Best Approach to Chronic Back Pain?" And I'm just going to kind of read some quotes here for the audience, and hopefully you guys can look up this article or reach out to us, and we'll can give it to you. But this is stuff you need to be able to educate your patients on it, and tell them, hey, this is not the way to go, especially if it's just for pain. Here's a quote by some high level doctors from big hospitals like HSS or Stanford and the like. Here's one quote: "In medicine, if you're able to stick a needle in a person, you are reimbursed at a much higher and better rate by insurance companies. So there is tremendous drive to perform invasive procedures." An internist on back pain, an expert on back pain, Richard Deo, who's done a lot of articles that we've read, Jer, an internist and an expert on back pain at the University of Washington, has published statistical analysis of existing research suggesting that spinal fusion and invasive procedures generally lack scientific rationale. With that being said, the rationale behind it, spinal instability is routinely given as a diagnosis to patients with chronic low back pain. It is a term used to justify an operation. And it's a great diagnosis because it can't be directly proven. This is by an unnamed surgeon who performs 2 to 3 fusions a week, right? And that goes to a lot of Peter O'Sullivan's work, Adrian Lowe's work. What is spinal instability? There's this myth of the core, and we need to activate the TRA. So how does things done on the pathoanatomical side, on the physician side, on the surgical side transition into what we think and do on the PT level? We always talk about instability. Well, instability from a ligamentous standpoint is way different than maybe dynamic instability, where maybe your muscles aren't firing correctly, or there's a motor patterning or motor sequence issue as well. And a lot of times we use the term, oh, you're unstable. Well, what does that really mean? And is that a harmful word to our patients? And can we choose a different word for our patients? I got a couple other quotes there, but I'll stop talking and let you, it seems like you want to chime in there, Jer.
Yeah, I guess you can't tell as much with the shades and stuff, but no, yeah, I think it used to be you commonly see on Facebook and Instagram for physical therapists is what's the number one cause of low back surgery or fusions, and it's just like pain, blah blah blah, some sort of diagnosis, and then one was zip code was one of the questions or one of the answers. And
oh, really?
Yeah. The answer is zip code. A lot of it's, again, a financial sort of thing. I mean, I can't imagine how much that costs and everything like that. And I get it. Again, they're business people too. The whole medical system in America is definitely a business sort of stuff, but it's one thing if, let's say, you're doing a placebo surgery, it's not maybe affecting that person or changing up their body or their perceptions of that person. But, what are we doing for this patient, again, down the lifespan? It starts to beg the question, and, we're starting to get fusions out at 20 years old and that sort of stuff. And I think you made some, good points about, the expectations. Let's take my eye surgery, for example. I went in, got a consultation on Tuesday, and by the end of the conversation, they're like, oh, we'll set you up for Thursday, and you'll be fine by, the course you have to teach this weekend with Brandon. And I was shocked. Like, they didn't give me, I just assumed, I was like, damn, fucking technology's gotten amazing lately. Damn, I'll be ready to rock and roll by the weekend. And a lot of times I put my head down, I couldn't look. And they're thinking, oh, we have a time slot on Thursday, let's fill it with this guy. Yeah, great. And I'm not dead or anything like that, but how does that affect my ability to perform, or our business and such and so forth? And I think that's where a lot of our issues come to be, is we're trying to have this balance of our pockets and business or finances and the patient's well-being. And I think a lot of the times that business / finance side overtakes, unfortunately, what the patients are experiencing. So hopefully that's something that changes. I remember in residency, an article was brought up of like the best back surgeon in America, or was like proclaimed or was rated as that. He was going and doing his surgeries, and he was constantly working on his craft, and he was saying it's like, there was no errors with how he's doing it, and he was cleaning up things, and he's like, he felt like he was getting better and better with how he was operating, and yet continued to have worse and worse outcomes. And then he just thought, he was like, I need to operate on more and more and more people, and then constantly kept getting worse and worse outcomes until he had to like take a step back and started to realize his surgeries weren't helping people. They weren't, especially for the long term, especially for pain. he started to realize like this isn't good. He's like, I'm hurting people more than helping them. And now he's still an amazing surgeon, but he's purely like a trauma-based surgeon for backs. Or when I think it even said that it's like progressive, like neurological issues and that sort of stuff. So at least he had insight to be like, shit, this isn't helping. Yet he was, trying to do in his best nature, like to try and get better. He was like constantly working on things, mentoring, following the best people. But at least he took a step back, and now he's only doing operations on the people that most need it. So that was a super cool article. And that's something that we should do as, all of us as clinicians. I always mention on the show, I reflect on the year before through some random, notes that I audit of myself. And I look back and I'm like, look at those things that I probably wouldn't have done. And I just try and evolve myself. And I think that's a good thing to do, and especially for chronic low back pain patients.
Yeah, to just to kind of piggyback and probably wrap up here, what you were saying, just two more quotes here from that Knife in the Back article. Here's a doctor from Stanford estimates that less than 25% of lumbar fusion operations he performs will be completely successful. Right. For the majority of patients, the surgery does not have dramatic impact on either pain or mobility. Right? And this kind of goes to what you were saying, that patient or that surgeon needs to be selective. We really should only be doing surgery for certain, people with certain types of pathologies that have glaring kind of red flags or kind of issues going on there. We're talking about the spine, at least. And the last one from HSS surgeon regularly sees spinal fusion patients who experience persistent pain after multiple operations. And that goes to the patient that we talked about earlier. Pain is not your indication. We now know that pain is made in the brain, not to say it's made up, but the way processed and everything is in the brain. Yes, there are external or peripheral nociceptive factors as well, but surgery is not going to clear that up, and we need to do a better job as clinicians, one, treating those patients with central sensitization or patients who have chronic pain. Right, there's a difference between patients who have chronic pain and chronic pain patients, right? And then being able to hopefully also not only treat it but educate our patients. Hey, this is probably not the route you want to go to. Let's try, let's give this a real concerted effort. And one of the things, I tell most of my patients, like on something like this, obviously every patient's a little different, but, let's give this, surgery is always going to be there. Let's give this a concerted 8-12 weeks, 3 times a week, where you're doing it. And that 3 times a week doesn't necessarily have to be in my office. If you're going to be compliant and do the stuff at home, great. But if you're not, then you need to be in here. But you can't say 12 weeks have passed and you only did, 10 days worth of stuff. It's not how it works. Just because we were here for 12 weeks doesn't mean it was actually 12 weeks or 8 weeks or whatever the number is. Explaining to them, changes aren't going to happen, if you're not doing it 3-4 days a week. There's 169 hours in a week. If I have you for 3 of them, we're less than 1% of that week. Try and put things in perspective there. Encourage people to move. Most people feel better if they move anyway. And we know here in America, movement's not the number one option for most people, especially lower socioeconomic areas.
Yeah. I think they brought up some good points with that. And, something they bring up is time, especially these, chronic pain patients. And I think we're kind of getting into this mode of, all right, we got to see people and discharge people. We can't see them for a prolonged period of time or anything like that. But especially these chronic pain patients, you're changing up you're trying to change up their whole mentality, their behaviors, years worth. I mean, I've had people who've had pain longer than I've been alive when I saw them at time of eval. Maybe not so much anymore because I'm getting older, but and definitely not for Brandon. He's ancient, but
thanks, bro. Appreciate it.
No problem. You got to give yourself time, and those conversations are going to take, there's layers. Well, I always say you got to peel back the layers, and it's not all done in one session. You're going to find new things, and it's going to different fears and other sort of things, past traumas that need to be, addressed, and it's going to take time. And that, exercise and endurance for and capacity for activity is going to take time to build up. You don't just go from, I'm an active individual, let me go run a marathon, even if I'm active. Now I have to build up my steps. So, give yourself time with these patients. You know, they've gone through a lot, both mental and physical trauma, which I always kind of find funny is like people will bring up things of like a motor vehicle accident was the cause of their issues 15, 20 years ago, of that trauma itself. And yet they want someone to go in there with hammers and stuff like that to cause some more trauma. But, make sure you kind of get, take the time to work on these patients. And Brandon, I know you see a lot of direct access and that sort of stuff. Of those individuals that you've seen that are purely direct access, low back pain, haven't really had any other input, how many of those, and you've been practicing for what, 8+ years, how many of those have ended up needing to have like a surgery? So probably pretty few.
Yeah. I'm sure there's been one or two actually, wait, that have never seen another medical provider.
Well, yeah, or no more than I guess a GP and that sort of stuff. Or
Yeah,
yeah,
I'd say for the most part, they haven't needed surgery. Am I going to say 100%? No, I'm sure I'm missing somebody.
yeah.
Just here off the top of my head, I remember having one guy, he was a CrossFit. He came in with a real bad shift. I can't remember. It wasn't my patient. It was one of my employees. This was a few years back. But I can't remember if he saw a surgeon prior to coming to see us. He might have ended up getting something. We were trying to tell him no, but he also wasn't listening or compliant. Like he would still go do handstand push-ups and try and lift through his pain. It's like, dude, you need to like at least give us a couple of weeks of not doing anything so we can make the necessary change. So that's one off the top of my head. But yeah, I'm sure there's been a couple but largely, they haven't needed. We had a patient this week, chronic pain for 2 years that, cleared up 90% within, we used her as a case study. And she was having numbness, tingling on her arms, headaches, couldn't wake up, would wake up with her both hands and arms asleep, had back pain too, had a history of some ridiculous stuff down her lower extremity as well. So usually those, just because you have chronic pain, just because you have numbness, tingling, doesn't necessarily require surgery. You just need the right intervention for the right patient at the right time.
Yep, that's all it's about. And again, some of those individuals do need to have a surgery, and it's, the right patient at the right time. It's, oh, we're getting progressive neurological, loss and that sort of stuff. We've tried even, a little like therapy and that sort of stuff, or preparation for the surgery. It's not getting better. All right, then, that person needs to have some sort of operation. So, but I feel like we should always get a crack at it. Obviously we're biased, but that's, the proof is in the pudding. There is, why I brought that up is, Brandon, think back and maybe pulled out 1, 2. I don't think we had one patient that did 1 or 2 sessions. I don't think she made it to this second. She had a ridic. She was coming to us first. Again, we didn't really get I think she may have only been 1. And I assumed she went to the ortho. I just never got, never heard from her again, try to follow up. And she may have went down that route, but, see that big change in difference if we get those people early, educate them, continue to get them moving, and change up their life. But yeah, I think that's pretty good to wrap up there. Anything else there, Brandon?
No, I guess we'll just make our announcements. We've got a bunch of courses slated for the rest of the year. We just had our cervical thoracic course, which was awesome. Jeremy taught him in the shades. He's a trooper. That was a great turnout. When we have 13, 14 people, great weekend. We have a private course the second week of October. Third week of October, we have the lumbar pelvic course down at Jeremy's place at Trifecta. We're doing a semi-private course in early November I believe the second week in November with Perfect Stride out in New York City. For anybody in New York, definitely check that out. They're awesome practice, doing great things with a lot of runners. The first week of November, November 6th, I believe, we have a 1-day fun extremity manipulation, upper and lower extremity. So that's a quick 1-day course. That's fun. And then we have our big banger course, spinal manipulation, at the beginning of December to end the year. And that's always, packed. So hopefully we see some people who listen to this podcast out in one of the courses. We also have our mentorship program and our manual therapy videos online that can be purchased if you guys are looking for a mentorship, looking for a residency or fellowship style, I guess, level and knowledge to improve your skill set. We have a hybrid model there. So definitely reach out to us. We'd be happy to fill you in more. Awesome. Anything else to add? Did I miss anything?
Now, by the time this bad boy's probably released, we'll also have another thing by, I guess, popular demand over the years. Brandon and I have gotten a lot of questions and asked for business mentorship, being that Brandon's has 2 offices. I'm on the verge of 2 offices, maybe hopefully a third. Some business advice for the expert clinician or the clinician that wants to really focus on outcomes and clinical excellence. So we have a company called the Rehab Coaches. So that'll be launched by the time this episode is released. I'm looking for a strong start in 2022. So if anybody's interested in that, feel free to reach out to me. And it's called the Rehab Coaches, and hopefully we can help some people along and start this entrepreneurial PT spirit in America.
Awesome, man. Yeah, definitely pumped to be a part of that, help you out with that. I know you've been talking about it for a while. Fortunately, things sometimes take a little longer, but we're going to do it. We'll get out there. We're still young in our careers. I guess one other thing, we're doing for those of you in New Jersey listening to us, we're doing the APTA New Jersey golf outing in November, or not November, October. I apologize, October 12th. IOSMT, our continue education arm of things, it will be one of the sponsors sponsoring the lunch. So definitely check us out. Check out, support APTA and J as a whole. You don't need to be a good golfer. Just go out, have some fun with a group of friends, network. Mm-hmm. And that's another opportunity. Hopefully we'll get to meet some people. So
well, we're 2 years running in a row where we've come dead last. They say we were last most honest. We are we have the lowest
score.
Yeah.
So I'm hoping we turn that around this year, though.
Yeah, so we're playing chess, not checkers, baby. We've saved ourselves that's a pretty expensive course, probably $400 or less, maybe $350 in playing a couple games of golf between me and Brandon for being
we get free rounds for being the worst.
Yeah, so I'm not mad about it. It's honestly the best policy, baby.
Yeah.
But all right. Well, thanks to everyone for listening in. Great episode, and cheers, everybody.
Cheers, guys.
Oh, I spilled some.
Oh, shit.